Pod.
Hello and welcome back to BNSSG Peds Pod. I'm Ruth Bowen. I'm a Bristol GP working for the BNSSG Training Hub, bringing child and young person education to primary care clinicians. And today I'm joined by David Capehorn, who some of you may remember came to speak to us previously about UTIs. David is a GP partner and an Honorary Associate Specialist in Paediatrics. And David, you seem to be balancing the worlds of paediatrics and primary care quite well. Do you mind telling us a little bit more about how you ended up where you are and where your expertise comes from?
I managed to con to lots of people I could do two jobs at once for a long period of time and nobody's really noticed. Yeah, the background was I originally started training in emergency medicine and very quickly realised that children's emergency medicine was what I enjoyed. And this was a very long time ago, before the world of children's emergency medicine really existed. So I've been around a long time now, in the last 35 years of a career. Went out to general practice and never quite left the hospital. If you hang around long enough, they give you an associate specialist title, you know.
Yeah, okay.
I think there might have been a bit more to it than that, but that's how the original background came, juggling the two. Became a partner in the practice I trained at, and then found, because I had a foot in both camps, as it were, started to be involved in lots of service development and generated a few ideas. And most people in BNSSG probably know me for the Paediatric Advisory Service that we actually innovated in South Gloss. It was the first of its kind in the country. And so we did that for about 15 years or so. As I said, most of those crossover developments between primary and secondary care paediatrics I've been involved with.
So you're very used to hearing our questions from primary care.
Indeed.
Very well placed to be answering my questions then today. David's kindly agreed to share some of his insights into commonly encountered parental and professional myths and pitfalls in primary care paediatrics. We're going to discuss lymphadenopathy, fever, investigating recurrent abdominal pain, and interpreting investigations in paediatrics, with some top tips thrown in as we go. So to start with, we're going to be discussing lymphadenopathy and answering the question, do we always have to investigate lymphadenopathy in children, and how worried should we be? To use a case to help bring this question to life, 3-year-old Charlie was seen in primary care in October with tonsillitis and 3 enlarged cervical lymph nodes, the largest measuring 1.5 centimetres across. He was asked to return for review. He returns in January, 3 months later. He's now been well for 8 weeks, with no further coughs or colds in the interim. He still has 3 enlarged cervical lymph nodes, 1.5 centimetres wide in the anterior triangle. David, what do we need to do?
Firstly, remember that it's quite normal. This is one of the commonest myths that we encounter, and one of the commonest things that I get written to by fellow GPs, the persistence of cervical lymphadenopathy. The first thing to remember is that it is likely, particularly with cervical lymphadenopathy, that it will persist throughout childhood. A study by Park showed that in this sort of age group, 3 or 4 years to 8 years, if you actually check them when they're not unwell, about 90% of them are going to have palpable cervical lymphadenopathy at any one time. It's part of our normal immune response. And we all know in primary care that these children get 6, 7, 8, 9, 10 infections a year. If each of them has a prodromal phase, an illness phase, and a recovery phase, basically means you're either ill or recovering from being ill for most of your early childhood. And that's what we know in general practice. So as a result, these lymph nodes, they never get a chance to calm down. And part of the problem is that, of course, we live in the world of adult guidance as well. If you look up adult guidance, it's something like 6 to 8 weeks persistence, and you should be considering investigating. And that just really doesn't apply in childhood. I think from a practical point of view, investigating also carries pitfalls. Let's face it, we're all terribly worried we're going to miss something serious. Leukemias, lymphomas. Children with leukemia present as ill children. An ill child's an ill child, whatever their lymph nodes are doing. And actually doing blood investigations, you could have a normal full blood count in a child with lymphoma. So that's not going to be particularly helpful. So you need clinical criteria, really, to determine whether these children have something seriously wrong with them or not. The other thing to remember is, from a practical point of view, most of them are going to be well children. This is a well child. And I don't know if you wanted me to run through a few of the criteria that we can use to determine which of these children we should investigate.
Absolutely, yes please.
There are 6 main criteria. The first is a rapidly changing lymph node. So the lymph node that suddenly doubles in size over the course of a week. Take notice of it. That's more likely to put you into the worry category. Significant lymph nodes in lots of areas of the body. There are lots of children who have those small, shotty lymph nodes in the groin area. You may even have tiny lymph nodes in the axillary area. But if you've got lymph nodes in several areas, take note of the child. For the reasons I've said, a child that looks significantly clinically unwell, take notice of them. Change in weight. One of my top tips is to weigh children at each consultation. A child that loses weight, that's always significant. Remember to examine children, as well as just feeling for lymph nodes in other parts of the body. Feel for whether they've got a liver or spleen. A palpable liver or spleen again raises the likelihood of something significant going on. And then, in terms of the individual lymph node, depends whose guidance you read, but a significant sized lymph node would be 3 centimetres or above, or a lymph node that has either an abnormal position, so for example a supraclavicular node, or has an abnormal feel to it. Get used to feeling normal reactive lymph nodes in children, that nice squashy feel. Sometimes they're quite painful for the children as well, but that's part of the reactive thing. The hard rubbery ones that aren't painful for the children when you palpate, that's when the alarm bells need to start ringing. Most of the studies show that if you use those clinical criteria, whether the child's unwell, whether there's been a change in weight, whether lymph nodes feel abnormal, whether there's been a rapid increase, whether there's lymph nodes elsewhere, if you tick all those boxes, but of 99% being likely that there's not a serious underlying cause, monitoring these children over time is really quite important. I spoke to one of my paediatric colleagues who runs the Rapid Access Clinic at the Children's Hospital, who, when they started running the clinic, I think had 300 or so that they looked at, children that were referred with concerns over lymph nodes. They didn't find a single serious cause in all those cases. And that's for the reasons, probably as we started the discussion, the children with the serious things, they're already presenting as seriously ill. So I'm not saying don't assess them, but use your clinical criteria to assess them.
And those guidelines of when to investigate, that's really helpful.
Yeah.
Thank you. That's a great overview. Moving on to fever. Fever causes a lot of parental anxiety, and assessing children with fever can be very difficult for clinicians. So again, let's think about a case here. Mum brings in 15-month-old Aaron with a 2-day history of cold, then becoming wheezy. He's been hot all day, but Mum couldn't get him to take any medicine. He's had 2 previous wheezy episodes with reasonable response to Ventolin, so Mum gave him some Ventolin via spacer this morning, but there was little response. On examination, his respiratory rate was 50, pulse 160, temperature 39.8, and he was very miserable and uncooperative. His chest sounded rattly and wheezy, but was quite difficult to hear through the crying. Mum's really worried about his high temperature. Would you be?
Not in itself. Feverish illness causes a great deal of parental anxiety, but the fever itself doesn't really predict anything for us as clinicians. We just know that they're hot and miserable, and they're difficult to assess as a result of being hot and miserable. And in that instance of the case that you've just described, yes, the child's miserable, but from the sound of it, it's fighting off my examination and crying. Those are all pretty good signs, aren't they?
Yeah, we quite like the uncooperative child.
Yeah, the child that's lying there floppy and not taking an interest in what you're doing, they're the ones we really worry about. So although the feverish illness is causing anxiety to mum, the fever itself isn't a concern and doesn't really predict anything for us. It was one of my former colleagues I worked with that many of the listeners will have known, Lisa Goldsworthy, who I think came up with the expression that fever was a confounder of illness rather than a predictor of illness.
Good phrase.
It just makes things a bit more difficult to assess. Fever just makes us all feel lousy, doesn't it? Even as adults, that horrible flu-y type feeling. And this child in that case that you just described, 15 months old, I think you mentioned, they're not going to be able to describe that they're just feeling awful. So obviously the caveat that we always make in paediatrics is be really wary about the really young children. So under 3 months, they haven't got a mature immune system. So any feverish illness in that age group really take notice of. But over that age, don't determine your management just on the basis of the fever itself. The fever is just going to confuse things. Trying to take the misery associated with the fever out of the equation by using antipyretics, that's part of the management. But in itself, the fever wouldn't concern me.
Brilliant, thank you. Feverish illnesses are one of the most common reasons that children present to primary care. And studies have shown that depending on the setting, 5 to 25% of feverish illnesses in children are due to serious bacterial illnesses. And there are quite a few tools that have been developed to help us identify those children. The one that we use most commonly in primary care, of course, being the NICE traffic light system. What do you think of these tools? How useful are they in primary care?
Again, I'd better put a rider on what I'm about to say. Anything I'm about to say now doesn't mean to say I don't want you to be using those tools, but I think you need to be really careful about relying on them completely. For the reasons we've said, feverish illness slightly distorts assessments of children. Although you've quoted those figures about the likelihood of serious infection within primary care, the likelihood of serious bacterial infection is actually very low. It would be very much at the 5% end of that range. 95% or more of what we see is viral illness. Most of these children are going to be fine. They're going to look unwell and miserable when they've got their feverish illness. And there have been a couple of studies that have looked at the usefulness of the traffic light tool. The first one as long ago as more than 10 years ago from a hospital viewpoint that was published in the BMJ, but the most recent one was actually published in the British Journal of General Practice and was actually published by our colleagues locally in Bristol. I think it was Professor Alistair Hay in the School of Primary Care. They looked at 6,000 or 7,000 children and tried to correlate them with subsequent admission to hospital and back-match them to their traffic light category. They found that a red categorization meant that there was just under 60% sensitivity of picking up the serious illness, but a specificity of pretty similar figures, 68%. So then they looked at red and amber together. And yes, you will get 100% sensitivity that way. You'll be guaranteed if you use the red and amber criteria that we won't be missing any serious bacterial infections.
That's going to be most children, really.
The problem then is that they discovered, this is directly from their paper, 5.7% specificity, which means that 95 out of 100 children that you send into hospital will have simple viral illnesses. Their conclusion was that actually as a tool for use in general practice alone, it really doesn't have a great deal of use because of those problems of the sensitivity and specificity. Now, that's not to say the criteria are very useful, looking for those things in the red, amber and green tools, but they can be distorted. They need to be interpreted in the context of how unwell and miserable. So, for example, that case that we discussed at the start, you would find they will definitely fit into the red and amber category. But you and I know in practical terms, if we could get some paracetamol into the child and have them calm down a little bit and reassess them, they're more likely to fit into the green category. So we're not saying don't use the tools, but use the tools with a degree of interpretation.
So more of an adjunct, but put them in the context of the child that you're seeing.
Absolutely.
Brilliant. And there's a few myths that I've heard from parents that I wondered if you could give an opinion on. So the first one is fevers above 40 degrees are dangerous because they can cause brain damage. What do you think about that?
Fevers from infections that are rising outside the nervous system, obviously we take away the nervous system ones, they don't cause brain damage. In fact, it's very unlikely that a feverish illness will cause those sorts of temperatures at all. Sadly, those are the sorts of temperatures that are likely to be achieved in those horrible cases we hear about with children or animals even being locked in a car on a hot day. That's the situation when that's going to happen. From an infective illness, no.
Okay. Anyone can have a seizure triggered by a fever. Is that true?
Well, it's about 4% of children have a seizure triggered by a fever. In general terms, most of them have a family history of it. We used to get taught, I don't know if the same myths perpetuate, that the height of fever was important or the change in temperature was important. We now know that probably it's a bit more complex than that. So yes, in theory, anybody can, but in practice, most of them won't.
Mm-hmm. Well, I agree. Even when I was taught, it was very much the rate of the fever going up that caused the seizure, we thought at the time. But actually, we now know that even if you give antipyretics and the fever doesn't go up,
make any
they can
difference.
still have the seizure.
Absolutely, yeah. So a proportion will have that as a response, whatever we do.
All fevers need to be treated with antipyretics.
Well, hopefully everybody knows the NICE fever guidance actually even specifies that we're giving medication for the misery associated with the fever. Just having a fever just makes you feel a bit uncomfortable. So we're actually giving it for the analgesic effect, really, the antipyretic effect. Bear in mind, this is part of our immune response. It's the body trying to deal with the infection. So the fever's actually quite good. And actually the feverish part of it turns on the immune system, doesn't it? So we shouldn't be treating the fever alone, but we don't want children to be miserable. And we also need to be able to assess children, and they're much easier to assess when they're comfortable and when they've stopped kicking and crying at you, as in the case example you gave.
Yeah. Without antipyretics, would the fever just keep going higher?
The brain knows when it's a bit too hot. So most fevers for infection won't go above 39, 40 degrees. They're quite rare. And even though they can go that high, they're usually still fairly harmless. One of the examples I often give when I'm explaining to parents is in the context of tonsillitis. You have a viral tonsillitis, you have a bacterial tonsillitis, and the height of the fever won't tell you one way or the other. If you think about glandular fever, it's a classic viral illness. You have a really high temperature with that. I remember I felt really miserable when I had that as a medical student. So you can't tell much from the height of the fever, and most of them are harmless anyway.
And I often have parents coming in saying they've given their child antipyretics, but the fever's not come down to normal, and that really worries them.
This is a classic, isn't it? And it's really important to remember to tell parents this in advance, because they give the Calpol, and because they're expecting the temperature to come down. When it hasn't, they're back on the phone to us. But the important thing to tell them is that you're giving the paracetamol to make their child feel better. So as long as they feel better, whether the temperatures come down or not really doesn't matter terribly much in most cases. As long as the child's looking well, that's the thing that trumps everything. That's a big top tip for people that are listening today, is that when you explain to people, give some paracetamol, give some ibuprofen. If John is looking and feeling better and running around eating a packet of crisps or whatever, that's the important thing. Whether the temperature is now 38 or 38.2 matters less.
I think we're very used to in medicine, aren't we, treating the person, not the numbers, but parents obviously see that differently.
Absolutely, yeah.
And if the fever's high, does that mean the cause is serious?
No, again, for the same reason we've discussed, but again, parents will ring us with that. And sometimes these things get perpetuated and there's information on the internet that perhaps isn't as accurate as it should be. Parents may be sitting perfectly happily at home with their child with a temperature of 38.3, and the child hasn't changed at all, but they've now measured it, it's 38.5, but it says on the internet, I must call the doctor if it's 38.5. As though the figure itself has some magic property to it. And it's important that we explain to the parents that it's actually how your child's looking that's more important.
Bit of a common thread here, and carrying on with that.
Yes.
Sometimes parents come in and they think that the exact height of the temperature is a predictor of illness, but it also predicts whether it's a bacterial illness or a viral illness. Yeah,
again, exactly that same thing. And sometimes I'll actually joke with parents and say, look, with the most serious illnesses, and let's face it, I'm a parent as well. As parents, we worry about our children. The most serious illnesses, sometimes, sadly, children don't get temperatures, as you know, because their bodies are overwhelmed by the infection. And so to have that focus totally on the level of fever, explain to parents, is going to be misleading them. How they look in themselves is going to trump anything.
So definitely fixating on the wrong thing then there.
Yeah.
Is it right that 37.5 degrees and above is a fever?
Not really. The first thing is all of us have varying normal body temperatures. It varies during the course of the day, peaks late afternoon, early evening. So 37.5 could be a completely normal temperature for a child. In general, 38 and above is probably reasonable to think that there's something going on. But to be honest, until you get to 38.5, most children will probably not show much in the way of symptomatology. They may be a bit more grumpy than normal, but there's lots of reasons for children being grumpy.
Yes, I know well, with two small children of my own. Practitioners often worry about the use of ibuprofen in feverish, wheezy children. Is it true that ibuprofen causes wheeze in children and we should avoid it in any children with asthma or viral wheeze?
This is a common myth that gets perpetuated. The only absolute contraindication to giving ibuprofen is a previous wheezy reaction to ibuprofen. Yes, if a parent said the last time he had ibuprofen, he was very ill and got very wheezy as a result, be a bit cautious. But other than that, no. And sometimes we have these bizarre situations. A child has perfectly happily had non-steroidals over a long period of time, and then at some stage has been prescribed subsequently a Ventolin inhaler, and then has been told, well, you must never have the ibuprofen again, despite the fact that they've perfectly happily had it on many previous occasions without any wheezy response. It's been refuted many times. There are a couple of studies. Archives of Disease in Childhood has been publishing studies for 20 years showing that there isn't a contraindication in wheezy children. The only absolute contraindication is a known reaction to the ibuprofen. If parents are worried, the other thing you can do is say, would you want to give the first dose while you're here with us?
Yeah.
Just monitor them for the first hour or two after giving the dose, and if they're fine, they're fine.
They can happily sit in the waiting room
Absolutely.
for a while after you see them. Yeah, brilliant. And as an aside from Aaron, practitioners also sometimes worry about the usefulness of salbutamol in younger children, for example in under ones. Does it work?
This is probably the most common perpetuated myth in paediatrics, because I remember being taught as a younger doctor that young children didn't have beta receptors, therefore there's no point in giving the Ventolin. I don't think biochemically that's true. The most important thing is the type of illness that you're dealing with. The older children, certainly from a year and above, they're most likely to have the viral-induced wheeze, the viral-induced bronchospasms that we're used to dealing with. Those younger children, they're more likely to be in the bronchiolitic group, and the mechanism's different. With the viral induced wheezes, they do get bronchospasm. That's why the airways are a bit more narrow. The younger children, the more bronchiolitic sort of age group, it's basically wet lungs, isn't it? It's mucus build-up in the lungs. And so they don't respond to Ventolin simply because the mechanism is the wrong mechanism. The problem is they sort of merge into each other, don't they? It's fairly easy to think about an 18-month or 2-year-old who's got the typical viral wheeze pattern. And it's fairly easy to distinguish that from a 3-month-old with a typical onset bronchiolitis. But once you get to the 8, 9, 10-month age, which group are they in? Well, if I'm in any doubt, I'll just trial the Ventolin. They'll either respond or they won't.
Okay, thank you. That's very helpful. So what would be your main take-home messages when it comes to the feverish child?
I think, first of all, reassure the parents that the fever is not the focus. The fever is obviously a concern from their point of view, but from our point of view isn't necessarily the thing that's going to determine what we do. Try to take away the misery associated with the fever, as NICE would describe it, by giving appropriate analgesia. Make sure it's an appropriate dose of it as well. Don't be misled by the parents who say, I gave some Calpol. Mm-hmm. Johnny may be 4 years old and the size of an 8-year-old. And if they've given 5 mils of a tiny dose of Calpol, it may simply not be enough to make Johnny feel better.
Yes, I've accused my husband of this before by massively underdosing our children. Yep.
So making sure that it's an age and weight appropriate dose of it. And use time as a diagnostic tool. In most cases, we have got a bit of time on our side. Most of us are pretty good in primary care of recognising the very sick children, those floppy, unresponsive or semi-responsive ones. In the case that we discussed, the child that's kicking and screaming and may just be miserable as a result of the fever, what we're looking for is an inappropriate tachycardia. So use your assessment tools by all means. I'm not saying don't use your traffic light system, but use them with a degree of caution and interpretation. Know that they will be distorted by a feverish illness. The case that we discussed, the child's kicking, screaming, uncomfortable, temperature, they'll be tachycardic. If we take that discomfort out of the equation, have them just settle down a little bit. If they remain tachycardic, that's more of a concern. So using the analgesia and time to make that assessment is the key.
Thank you. So moving on to our next area and thinking about the myths around the role of tests in recurrent abdominal pain in children. 6-year-old Alfie has had intermittent abdominal pain over a few months. His parents report that he goes days without his bowels opening and then other times has uncontrollable diarrhoea. He's not lost weight or crossed centiles. Examination reveals tenderness in the left side of his abdomen, but he complains of pain right up to the epigastrium. What do you think might be going on with this case and what would you do?
Well, the first thing to take note of is that he's had several months' history of abdominal pain, but he's not lost weight and he's not crossed the centiles. So you'll forgive me, I'm going to reiterate one of my top tips from earlier. Whoever's been assessing this child, they've been taking the weight. That's key.
Brilliant.
So that takes away some of the worry and anxiety to start with. So we've got a child who's got left-sided abdominal pain, I think you said. Yes. Probably had some episodes of abdominal pain and then occasionally diarrhea. I'm immediately thinking, is this a child who's got constipation with a bit of overflow? I'm not thinking serious at the moment for the reasons we said. We've got a child that's actually maintaining their weight. So I'm not going to be thinking of doing a great deal of more intensive investigation in this child. Very often parents are worried that this is some sort of food-related problem, an intolerance. One of the ways that you can make an assessment of these children is actually to ask parents to do a food and stool diary. Very often that will reveal where parents perhaps haven't appreciated, particularly at this sort of age where children are starting to become a bit more independent of their parents, that they may not be aware that they go several days without their bowels open or that they're only passing rabbit droppings. You and I have both been at conferences where Brenda Cheer from the ERIC charity, the bowel charity, has been there. And she said it's simpler to assume they're all constipated until proved that they're not. I think there's a bit of truth in that, to be honest. And I think it's a reasonable starting point to say that, look, child's well, hasn't lost weight. I've got a bit of time. Let's do a food and stool diary. It might address any concerns that whether there's a food-related pattern to this, but it might also establish the fact that it's actually the bowel pattern that's the issue.
And their parents are often asking about tests for different foods, aren't they, as well,
yes.
and seeing if they've got intolerances there.
Yes.
But the answer is very much, unfortunately, it has to be a diary.
Absolutely.
And start from there.
Indeed.
Can you tell us a bit more about recurrent abdominal pain? So it's something we see a lot of, and I dare say in primary care we often struggle with. What is recurrent abdominal pain in children? And do you mind guiding us through when should we be investigating it?
I mean, the first thing is, in terms of a definition, there is an agreed definition. A child has to be over the age of 3 to fit into the category. They have to have had 3 or more episodes of abdominal pain over a 3-month period that's sufficient to limit their activities. So whether that's going to school or whether they're leisure activities. So it's the rule of 3. So 3 years old, 3 episodes over a 3-month period.
Quite nice and easy to remember.
Yeah, it's designed for Capehorn memory. There are various different subgroups. I don't think we've got time today. It'd be a double podcast to go through all the different subtypes of recurrent abdominal pain. But we're talking about conditions not dissimilar to the adults that we see with the functional abdominal pain or functional abdominal pain syndrome, which is where you get headaches associated with the abdominal pain, or abdominal migraine, irritable bowel syndrome. They're all part of that subgroup, and you might have heard of the Rome criteria. They're easy to look up. Bristol Children's Hospital does a very simple summary of the different criteria. But if you lump them all together, it said that anything about 14% or so of children will have episodes of recurrent abdominal pain, but probably 5 to 10% of them have an organic cause. So more than 90% of them, probably more in primary care, will have a non-organic cause.
But a great deal of anxiety for families and often a lot of school mess, so it can be quite tricky. And when should we be investigating these children?
Without making it sound too simple, most of them should be obvious. Because if I run through a list of what are described as the alarm symptoms, most of these should be fairly obvious. So involuntary weight loss. I'm going to reiterate again about the weighing children at each consultation. When I was providing the Primary Care Paediatrics service and taking lots and lots of emails from my colleagues, one of the things that used to drive me a bit potty was, please would you see this child who's had abdominal pain for 18 months and we've done X, Y, Z tests, but nobody over the 18 months has actually measured and weighed the child to make sure that they were growing. Way opportunistically, it takes a couple of seconds to pop a child on the scales and have a record. Involuntary weight loss, faltering growth, and clearly anything you find abnormal on examination. If there's a lump, there's a lump. So those are fairly obvious ones. GI bleeding, that's an obvious symptom that doesn't necessarily mean it's a serious cause, but raises the alarm. Abdominal pain in an unusual area. It's actually very, very common to get left-sided abdominal pain. That's the last bit of your bowel before it goes down into your anus to pass your stool. But having right upper quadrant pain is more unusual in a child. So a pain in an unusual area. Clearly, unexplained fevers, urinary symptoms, those sorts of symptoms in association with recurrent abdominal pain raises the possibility of an organic cause. And then there are other things like jaundice. And strong family history. We just need to be a little bit cautious. If there's a strong family history of an inflammatory bowel disease, celiac disease, clearly it just raises the possibilities. But most of those are fairly obvious from the history, aren't they? They don't involve any clever tests. Those are things that we can establish just by asking a few simple questions. So those alarm symptoms can raise the possibility that this might be a child that I do need to investigate, bearing in mind that 90% of them won't be.
So with a child like Alfie,
yes,
what would you do?
Lots of reassurance. And I would reiterate that the mainstay of your management should be reassurance at each stage. Agree an end point with the parents as well. Start with the explanation of children of this age get recurrent abdominal pain. Most of the time we don't find a serious cause. We may be able to elucidate some pattern by doing a diary together. We may not, but most of the time these children are fine as long as Alfie's growing and doing well otherwise. We just need to manage that situation. So lots and lots of reassurance. Very careful history to make sure about the alarm symptoms. Thorough examination, that's part of the management. You and I know that probably we're not going to find a great deal on examination, but the process of going through the examination is really important to parents to make sure that the child's been thoroughly assessed. And that examination should be thorough, just to check for anemia, organomegaly, or whatever. So it's really important that you go through that process of assessment, even though you know that in the majority of cases, a child who's thriving and well isn't going to have a serious cause. And I probably wouldn't take things any further other than perhaps a urine dip at that stage in the majority of cases. I know that there is always a query about a celiac test. And in fact, if you look at our local guidance at Bristol Children's Hospital, and if you talk to various of my paediatric colleagues, there's sometimes a differing opinion about the importance of doing a celiac test. You and I think, we're both together with one of our gastro colleagues who says that we don't do enough of them. I know other paediatric doctors who say we do far too many of them. I don't know about you, but the vast majority in primary care are negative. I think we have to do it in the context clinically. Like I said, I think with a strong family history and with any other concerns about the child, I think I probably would be doing a celiac screen. In this particular case, I think we've got a good history there of a child who's probably just got some constipation. And I think without a strong family history and a child who's growing, without anything else emerging on the diary that there was a particular food-related thing, I probably wouldn't be. So I think I have to leave that one with a caveat of it depends.
And as part of your examination, would you include a perianal exam?
I probably would. Apart from anything else, things like the inflammatory bowel diseases, having a look at the anal region is really quite important.
And presumably in girls who are a little bit older, then you'd always do a urine pregnancy
Absolutely.
test as well, even if they've not had their first period.
Indeed.
Thank you. So coming on to our last area of blood investigations, blood results are notoriously difficult to interpret in children.
Yes.
So a few questions for you around these. Can we treat normal ranges as the same as for adults?
In short, no. Let's take something as simple as a full blood count, looking for haemoglobin. I don't know if you've ever seen the printouts from Great Ormond Street about where they will literally give a normal range down to the day. Let's say we get a haemoglobin in childhood of 10.5. That would be a bit borderline in a really young child, primary school age maybe. It would be an anemia in a secondary school age child. In a toddler, it might be quite normal. So again, you need to interpret in the context of that. And many laboratories will actually quote a single normal range. So you do need to interpret. And the problem is, particularly with parents perhaps having online access, if it has a star next to it, from a parent point of view, it's abnormal. So it may be important for us to explain the results in the context of what we're expecting, that actually a haemoglobin at 10.5 in a 2 or 3 year old might be completely normal.
And how would you treat an iron deficiency without anemia, whilst we're talking about anemia in a child?
That's a difficult one. If you talk to many of my paediatric colleagues, and I know again you've done the same, they would say they probably wouldn't, because we should be looking for the haemoglobin first. Ferritin has actually a really, really poor guide to iron stores in childhood for all sorts of reasons. In general, pretty much all young children are relatively iron deficient compared with adults, if you look at adult ranges. Ferritin is acute phase protein. So it's used up at times of viral infection, and for the reasons we said earlier on, children are having viral infections all the time, so you may have an artificially raised or lowered ferritin as a result. So I'd be a little bit cautious about interpreting ferritin on its own. If a child's otherwise well and their haemoglobin is normal, but the ferritin has come back a little bit low, I would certainly be talking to the parents about dietary changes, not necessarily the iron-containing foods, but I'm a parent as well. Getting your children to eat fruit and vegetables is actually quite difficult, isn't it? It doesn't matter how much iron you've got in your diet. If you've got very little vitamin C in your diet, you're not going to absorb it, are you? So I would certainly be encouraging dietary changes in the first instance. If parents want to give a multivitamin to their children, I don't feel very strongly about it. I know people's opinions vary, but I probably wouldn't be prescribing iron supplements. They carry all sorts of problems in their own right. In a child who's not anemic, I think I'd be going dietary, and or if you want to top up with a multivitamin, that's fine.
And particularly going back to earlier when we were talking about how common it is for children to be constipated.
Absolutely.
And how we often can't tell. We could be
Absolutely.
creating a lot of problems there.
Absolutely.
Thank you. And sometimes we do blood tests on children in primary care because parents are worried their children keep getting ill or are run down after a virus. Is there anything we need to be cautious of when we're requesting and interpreting those sorts of blood tests?
I suppose the first thing I would say at that stage is don't do them. Again, go back to your clinical criteria. Is the child growing? Are they well? Is this a typical pattern of recurrent viral illness? We've already reiterated several times today that this is normal in childhood. One of the things I would try to distinguish is between normal illnesses of childhood, earaches, sore throats, runny noses, tummy upsets. They're normal patterns of illness. They're very different from pneumonia, cellulitis, serious things that cause a child to be in hospital.
And I've heard that it's normal to have up to 15
Absolutely.
minor illnesses over
It
the
is,
years.
and many of them, the parents won't even know. They'll dismiss it as a snuffly nose for a day or two. Actually, it's their immune system fighting off the latest coryza that's been knocking around. And certainly talking to my colleagues at the Children's Hospital, when you're looking for children that may have a potential immune problem, for example, they're not going to get those typical normal childhood illnesses and still be thriving. They tend not to thrive. They tend to get more serious illnesses. So what are we looking for in those tests in the first place? I think you're unlikely to pick things up. And you may end up digging yourself a bit of a hole, because typically parents perhaps presenting on first week, second week, maybe third week into the illness, it may be 2 illnesses back to back. We relent. We think, okay, well, I will do a full blood count. Some of the findings that we'll get may then cause extra problems. So, for example, after a viral illness, a little bit of a drop in neutrophils, so you may have a mild neutropenia. That's a typical post-viral finding. You may have raised platelets. Platelets cause immense amounts of worry. I've had 2 inquiries from my own colleagues this week because the platelets have come back slightly elevated. They've come back at 480, 500. What do I need to do? Well, nothing, because that's a mild thrombocytosis as a response to a viral illness. And actually, it typically peaks 2 to 3 weeks into the illness, which of course is precisely the time when we've come under pressure to do those blood tests in the first place. And if you're not aware of those changes, that then can cause extra anxiety because there's a feel of need. Well, should I be doing the blood test again to see that it goes back to normal, even though Johnny is now running around completely well? So you can dig yourself a big hole. Obviously, I'm not saying don't investigate, but use those clinical criteria first. If it's typical viral illnesses, the child is thriving, the child is well, then there's probably no need to do it. But beware of the problems that you might be creating down the line in terms of interpreting those results.
And because those are normal changes, are you suggesting then that you wouldn't necessarily repeat them if they're not extravagantly high?
Absolutely. There's a big difference between, let's take the neutrophil count. There's a big difference between post-viral having a neutrophil count of 1.8 and the child now being completely well and running around and having a finding of 1.1. So interpret it in a clinical context. Typically to have a mild neutropenia in a post-viral illness is very common. Likewise, the raised platelets of 500 in the post-viral situation. Go on your clinical criteria. If the child is well and back to normal, then you probably don't need to be repeating them.
And you mentioned the ferritin earlier in terms of it's an acute phase protein, and that will obviously go up as well with the viral illness.
Yeah.
Creatinine is another really tricky one.
Oh, yes.
How do we interpret creatinine in childhood?
It's difficult, is the short answer, and you probably can't in isolation. We all know creatinine varies with a range of things, illness, with hydration status and so on, but it also rises throughout childhood and changes according to your muscle mass and your pubertal status and so on. So you can't interpret creatinine on its own. Unfortunately, you won't get an EGFR in childhood because the calculators are not accurate, but you can do an estimated EGFR yourself with a simple formula. You take the height of the child in centimetres, multiply it by 40 and divide by the creatinine. So if you get a creatinine that's raised, you need also to have had the height of the child measured at the same time. So my top tip, if you're considering doing some kidney function tests on a child, make sure you measure the height of the child at the same time. Because if it comes back elevated, you want to be able to calculate the EGFR.
And that'll be a heart sink moment otherwise.
It will, indeed.
Okay. Is there anything else that we need to be doing? So if the creatinine is raised, but there's a normal EGFR, are you happy with that? We don't need to be bringing them back in and doing blood pressures, urine dips?
I think it depends on the context in which you're doing it. Sometimes blood tests are done for reassurance sake. I think in that context, this is likely to be a physiological change, with change of muscle mass for the reasons that I've said. And then I think it's reasonable to just draw a line under things if the calculated EGFR is normal. If you're doing it because you've decided to investigate a child with recurrent abdominal pain because they've got loin pain or something, first of all, you probably should have measured the blood pressure in the first place, and you probably should have done a urine dip. So hopefully the creatinine and the EGFR is the last step of that. It depends on the context. But if you've got a normal calculated EGFR, a normal blood pressure, and bear in mind that varies according to height as well. Height blood pressure centile charts, if you just put that into a search engine, they'll come up for you. So you need the height for that as well. So normal urine dip, normal blood pressure, normal calculated EGFR, even though the creatinine is starred as being above the normal range, the child is probably normal from a kidney point of view.
Thank you. And it's hard to imagine, to be honest, that we would be doing U&Es without having done the urine and the blood pressure.
I think it's...
But they are very much around the clinical picture rather than from interpreting the high creatinine with the normal EGFR. Brilliant, thank you. Are there any other quirks of blood test results during childhood that you think are worth mentioning?
Well, the other one that causes a bit of anxiety for people is, of course, alkaline phosphatase, which is typically elevated because of the growth phases in childhood, bone outphos. And that's particularly the case, obviously, at puberty. I get a regular supply of, I think this is probably due to their growth, but can you just reassure me type emails? But yeah, outside any other clinical context, a raised outphos is probably going to be due to growth.
Thank you. That's given some really good insights into interpreting bloods in children, and plenty of top tips that you've thrown in there. Just to close, are there any particular resources that you would want to signpost clinicians or families to relating to any of the myths or pitfalls that we've discussed today?
Directing parents to Patient UK NHS sites so that they're getting the proper advice regarding fevers, because there are unfortunately, lots of sites there that give lots of misleading information. The Children's Hospital guidelines are actually really good for the GPs, the Remedy site, the GP guidance, and all the usual resources. So forgive me plugging some of my stuff, but I write things for Pulse, and looking at the top tips and pitfalls on those sorts of sites are quite useful for the clinicians as well.
Thank you. And you've covered quite a lot of common myths and pitfalls in primary care paediatrics and as the associated top tips. Have you got any key take-home messages that you really wouldn't want primary care clinicians listening to forget?
The big one is the weighing children. I've reiterated that several times, so I apologise for doing so again. But weighing children at each consultation. We're often monitoring children for an illness over a period of time. Children should be growing. Children who aren't growing need investigation. Doesn't matter what the underlying cause is. The second is try to reassure parents about what's normal. For them to understand what's normal, for them to understand that lymph glands come up, they don't necessarily go down because children keep getting viral illnesses, but as long as the child is well and growing otherwise is important. Reiterating that the fever itself isn't the problem, we need to look at what's the cause of the fever. So making sure that parents understand why we're making these decisions is probably the big message I would get through.
And stops them keep coming back again and again,
Absolutely.
asking the same questions.
Absolutely.
I think the key take-home messages for me, weighing children is one of them. So I actually think I was pretty good at weighing children, but the more I speak to paediatricians or GPs with an interest in paediatrics, the more I think I should be doing it more than I am. How common the persistent lymphadenopathy is in childhood, I found those specific indications of when to investigate really helpful. So the rapid growth, the more than 3 centimetres, the organomegaly, that was really helpful. And it's really helpful as well knowing quite how common secondary thrombocytosis is after viral illness in children, and that it peaks around week 2 to 3. I didn't realise that was the peak point, so that's really helpful to know as well. Yeah. Thank you so much, David.
That's right. You're welcome.
Do leave feedback on these episodes. Let me know if there's any topics that you'd like to hear, and look out for future episodes on the 16th of each month. For now, goodbye. The contents of these podcasts are for educational purposes, aimed at primary care healthcare professionals only. They do not substitute professional medical advice or consultations with healthcare professionals. Information presented is the opinion of the healthcare professional interviewed, based on their interpretation of best practice and guidelines at the time of the interview. It is the listener's responsibility to compare information given with up-to-date national and local guidelines. The BNSSG Training Hub, Ruth Bowen, and interviewees are not liable for any clinical decisions made as a result of this podcast.